Hello, my name is Michelle Dorch, and I'm presenting for Dr. Herd's Group 8 for pharmacology. Our case study is about a 47-year-old male who presents to the clinic with a complaint that his heartburn is keeping him up at night. He's having chest pain and discomfort in his esophagus. He states he wakes up and feels as if he's not able to breathe in the middle of the night. This, along with mild sleep apnea, causes him sleep disturbances and anxiety. His father also had a heart attack before the age of 50, so this also produces anxiety. The patient is 5'9" and 220 pounds. His BMI is 32.5. And he reports he is a social drinker, and he eats food that aggravates his symptoms. He doesn't take any regular medications, but he does take PRN antacids for relief, symptomatic relief. His chest x-ray and EKG are negative, and he is then diagnosed with gastroesophageal reflux disease, or also known as Gerd.
What is Gerd? Gerd, or GERD, stands for gastroesophageal reflux disease, which results from the reflux of chyme from the stomach into the esophagus, usually due to dysfunction of resting tone of the lower esophageal sphincter, or the LES, which normally maintains the pressure barrier between the two. Gerd is common, affecting approximately 10 to 27% of the population, and is often referred to by patients as acid reflux or heartburn due to the acid taste in the back of the mouth or burning sensation felt in the chest, often aggravated by meals and by lying down and relieved by sitting up. Sore throat, hoarseness, and halitosis are often also associated with Gerd. Diagnosis is mostly based on response to treatment, as there are no recommendations for diagnostic testing. Treatments generally include drug therapy and lifestyle management.
So what would be the initial management plan for GERD? Initial GERD treatment for patients with mild GERD symptoms or dyspepsia should include lifestyle management and use of over-the-counter antacids such as calcium carbonate or TOMS, or H2 receptor antagonists such as cimetidine or Tagamet to control the symptoms. The goal should be to reduce or eliminate symptoms, heal any esophageal lesions, manage or prevent any complications, and prevent relapse. Lifestyle management includes weight loss, anti-reflux maneuvers such as sleeping with the head of the bed elevated 6 to 8 inches, and avoid recumbent position within 3 hours of eating, and dietary considerations. Patients should be taught to eat moderate amount of foods with each meal and avoid eating around 3 hours prior to going to bed. Education should also include the types of food and medications that affect LAS tone and stop smoking since tobacco decreases the lower esophageal tone. Initial treatment for patients with moderate to severe GERD or erosive disease should include or should start with a proton pump inhibitor for 8 weeks as a first line of treatment. If symptoms are relieved, they can be weaned off the PPI. But if the patient develops erosive esophagitis or virus disease, then the patient can be referred to a gastroenterologist. Now let's try to discuss patient education to patients having gastroesophageal reflux. The first one will be promotion of a healthy diet to achieve an ideal body weight. Being overweight or obese can increase the abdominal pressure, causing the food to back up into the esophagus. Second one will be avoidance of cigarette smoking. We all know that cigarette smoke is an irritant, and the nicotine from the tobacco relaxes the lower esophageal sphincter tone. Cigarette smoking can also reduce the amount of saliva that one produces, and a lack of saliva can make the esophagus lining more sensitive to stomach acids. It can also cause your heartburn to be more severe. Third one will be avoidance of alcohol. Drinking alcohol increases the likelihood that the stomach acid will back up into the esophagus. Avoidance of foods such as chocolates, caffeine, fatty foods, greasy foods, spicy foods, citrus products, tomato-based products, mints, or mint-flavored foods. These foods results in decreased lower esophageal sphincter tone, leading to regurgitation. Um, and avoidance of any over-the-counter medications, to include aspirin and ibuprofen. These medications increases and irritates the gastric lining. This also includes certain prescription medications for asthma, emphysema, and osteoporosis. Older adults are or has an increased risk of having GERD. It's because of the muscles in the esophagus that is weak. That also leads to regurgitation. Prior to taking any medication, a person should check with a provider, especially if they're having some reflux, to check if they have hernia. It's because hiatal hernia has a manifestation similar to GERD. Hiatal hernia occurs when part of the stomach protrudes through the muscles and into the chest wall, and the major symptoms of this is backflow of stomach acids into the esophagus, which is similar to gastroesophageal reflux.
Which complications can occur with continued symptoms and left untreated? If left untreated, gastroesophageal reflux disease (GERD) can cause both esophageal and extraesophageal complications. The complications that develop are due both to the inflammation and damage from the reflux material, as well as secondary to the reparative process that occurs. Complications directly related to the esophagus include erosive esophagitis, Barrett's esophagus, and esophageal stricture. In erosive esophagitis, the surface layers of the esophagus mucosa become necrosed due to excessive contact with the reflux of acid and pepsin. Patients with this can be asymptomatic or have symptoms of heartburn, regurg, or difficult and painful swallowing. Barrett's esophagus is a condition that results from the body's reparative process due to the damage in the esophagus. In this condition, metaplastic columnar epithelial cells replace the stratified squamous epithelium that usually line the distal esophagus. Long segment Barrett's esophagus can be complicated by ulceration, stricture, and hemorrhage. This cellular process occurs in patients with chronic GERD and can predispose them to esophageal cancer. Esophageal strictures are also the result of the body's attempt to heal. In the body's healing process of ulcers that develop in the esophagus, collagen is deposited, and over time, the collagen fibers contract and the lumen is narrowed. Patients can present with difficult swallowing solid food and episodic food impaction. Extraesophageal complications from GERD include asthma, larynx complications, and more. GERD is often seen in patients with asthma and has been identified as a potential trigger for attacks. It is thought that esophageal acid may cause bronchoconstriction and exacerbate the obstruction of airflow. Otolaryngologic complications include laryngitis and laryngeal and tracheal stenosis. Reflux and contact of gastric contents to the larynx and pharyngeal mucosa can cause damage as well. Patients can develop chronic laryngitis and would present with symptoms of change in voice, hoarseness, throat clearing, persistent cough, or sensation of a lump in their throat. This reflux into the larynx area can also lead to stenosis in the larynx and trachea. Patients with stenosis in this area would present with central airway obstruction like dyspnea, cough, and even hemoptysis. The degree of symptoms depends on the degree of stenosis. Additional complications of chronic GERD include chronic cough, dental erosion, chronic sinusitis, recurrent pneumonitis, and an associated increased risk for esophageal, laryngeal, and lung cancers.
What are some risk factors for GERDs? Some risk factors that increase the risk of GERD include obesity, bulging of the top of the stomach into the diaphragm, such as hiatal hernia, pregnancy, connective tissue disorders such as scleroderma, delaying emptying a stomach. Some factors that also aggravate acid reflux would be smoking, eating fatty foods at night, eating large amounts of meals at night, or drinking certain beverages like alcohol or coffee, and then also taking certain medications such as aspirin.
Key points and conclusions. Primary management of GERD are lifestyle modifications, including weight loss and anti-reflux regimen. Medications such as antacid, H2 receptor agonists and PPIs may be necessary in treating symptoms of GERD. It is very important to control symptoms of reflux to avoid complications such as Barrett's esophagus, strictures, and erosions that can lead to cancer. External factors can contribute to GERD, including allergies, asthma, anatomical abnormalities, and upper respiratory illness. Long-term PPI therapy in uncontrolled GERD symptoms may need to be monitored by a GI specialist. Questions for the audience. Number 1. What are the major modifiable and non-modifiable risk factors for GERD? Number 2. Are some patient population more at risk for GERD complications than others? Are there demographics or socioeconomic factors? Number 3. Is GERD more prevalent in certain parts of the world than others? What may be some factors contributing to this? Thank you for listening to our group's presentation.